So these are the four bullet points from my talk. I'm going to tell you how now we have expanded the indications for patients that are at low risk with surgery. We have new transcatheter valves to deal with some of the limitations we have with the two commercial systems we have available. We have now a trial that is testing early intervention. And finally, for many patients, having a stroke during a procedure is worse than dying. It's a very severe complication, and we're trying to have the number as close as zero as possible with some other devices. So what happened in 2019? We had two trials using commercially available valves in patients that have very low surgical risk. So we compared these transcatheter valves with surgery. Why is this important? Because this is 80% of patients getting surgery in the United States are considered low risk. These patients are younger, so therefore we need to start worrying about other issues. Durability of the transcatheter valves. What if they need a stent? Can we access the coronary arteries? What if they get a pacemaker during the transcatheter valve replacement? What are the implications of that? So we really want to have a perfect result. Surgery has been around for 50 years, and we know they have excellent outcomes. So we were not comparing ourselves with a new technology. And finally, many of these patients are going to outlive their valves. What are going to be their options down the road? About 1 in 4 of these patients will receive a mechanical valve. And so these are valves that tend to last forever. So the strategy that we're here, assuming that we're going to be able to replace this valve every 10 years or so using a growing approach. And these have been the results. There were 2 pivotal trials that were presented and published last year. This is for one of the 2 devices, the Sentinel Device, and you can see the winner was clearly the transcatheter option. The same was seen with the other device. The Medtronic device had a similar design with death, stroke, and rehospitalization, and once again the winner was the transcatheter valve. The issue that hasn't been addressed by these trials is that about 1 in 3 patients did not qualify because they had anatomic exclusion criteria. What do I mean by that? We'll do a CAT scan. Dr. Calvacante will call us and say, this is not a good case for a transcatheter valve. Why? Because the risk of rupturing the annulus is too high, and that is usually a very serious complication. Or we think that the interaction between the calcium and the metal on the stent is not going to be favorable, and therefore you may have a leak around that, and that is something that we don't want to have. Cases that will look like this. You have a lot of calcium in a location where you don't want to see calcium. So now we have new devices that can mitigate that. This is one of them. It's a new transcatheter valve that was available a number of years ago, has been improved, and now is available commercially. And you can see that has certain advantages. It can be position, it can be the liver. You like the result, you can recapture, and it has a very, very good sealing, so you can treat patients like this without any concerns about annular rupture. There was 0 annular rupture in the clinical trial. And this is a real case where normally we will expect to see a fair amount of blood around that, and you can see almost a perfect result. And so these are cases where in the past we would have said no to. You need surgery, but now we can treat. So now we're putting these valves in younger patients who may need stents, may need additional work down the road. How do we access those coronaries? Well, this is another valve that is not commercially available in the US, but it is in Europe. We're part of this trial that hopefully will lead to approval. So this is how this valve is deployed. It's a relatively straightforward procedure to do, similar to the ones we have commercially available, and with excellent sealing effects and very low gradients. So we're moving from a field of only 2 transcatheter valves to hopefully 4 or 5 in the next few years. The early TAVR trial, as you see here, we're now testing the concept of early intervention. This is a clinical trial we are fortunate to be part of, and the idea we're trying to test is, do we need to wait for symptoms, or can we do this procedure before symptoms develop in asymptomatic patients that have severe aortic stenosis? And finally, a stroke. This is a complication that we all fear, physicians, patients, and we want this number to be 0. We want 0 strokes with this procedure. So the idea that some engineers had is, why if we capture those debris before they get to the brain? What if we put filters in the arteries here and we capture them, and then those filters can be retrieved? So this is the device. It's called a Sentinel Device, and you can see the two filters. One is placed on the right side, one is placed on the left. And this is what you can get after the procedure. When you retrieve them, you can sometimes visualize this. More often than not, you can see them under a microscope. If you put this under a microscope, 99% of the time you will see little debris. These are some of the signals from the clinical trial, a significant reduction in the number of strokes. So we want this number to be 0. So this is what we're trying to achieve. So as you know, Mick Jagger had this procedure done this year. And this is him 6 weeks after the procedure. He was able to start the tour again. And this is a real video that he posted in Twitter